Yeah, so
did you get any more feedback on that article?
oh, it's welcome to the 2018-19 Grand Rounds for the School of Population Public Health. And it's going to be a terrific kickoff. When I was talking to Larry about setting this up, it was the concept of, gosh, all of us who are going to be in the audience had to have gotten here somehow. So the concept of transportation being a part of public health is a no-brainer. Right? That's we are public health dedicated to preservation of health, not trying to pick up the pieces after ill health comes. So welcome, and hopefully this is going to be for you a very valuable session, not only today, but the other two for this term are going to be October 26th. Kim Schoner-Reichel is taking the lead on that, and November 23rd, Sterling Bryant is taking the lead on that round. So it's going to be a fun poll. Okay, so pointing out for our online audience that questions can be tweeted to the hashtag that you see up there. And for those claiming CME credit, that's the information that you need to be able to claim that credit. Okay, so I would like to introduce this morning's talk and our speakers. So where matters health and economic impact of the built and natural environment? What excited me about this particular presentation is the evidence to action aspect of it, that we're taking what we, as you're in the ivory tower, that took you a while to get here through the rain, actually has a translation and a meaning to the general public. And this is just a wonderful collaboration that's happening between people in government and in the health authority as well as academia. So we're going to be exploring that unique partnership, and it's going to be, I'm going to let Larry take the lead on introducing that, but I'd like to introduce our speakers. So Professor Larry Frank is Professor of Sustainable Transportation and Public Health, and is specialized in the interaction between land use, travel behavior, air quality, and health. So Larry is the author of Walkability and Walkability Index. And he's had a terrific career that spanned decades, and is the author not only of 150 publications, but also co-author of leading books, Health and Community Design, Urban Sprawl, and Public Health. Our second presenter is going to be James Stiver, and he's with Metro Vancouver, Manager of Growth Management and Transportation, and is responsible for the implementation and administration of Metro 2040. So those of you in the audience are going to be young enough to enjoy looking at 2040. Who knows about the rest of us old people. And regional growth strategy, planning, and policy. And holds degrees in urban and regional planning and local economic development. Our third speaker, Lyle Walker, is a registered professional planner with 20 years of experience helping communities and organizations clarify and advance their land use, transportation, and sustainability objectives. So Lyle is with TransLink and holds an MSc in planning from UBC. So alum come back to enjoy UBC. And our fourth speaker will be Dr. James Liu, is a medical health officer for environmental health at the Vancouver Coastal Health Authority, and provides leadership on environmental health assessment, environmental health policy planning, and evaluation. And Dr. Liu began his public health career working with Cariboo-Chilcotin region in British Columbia, is also a grad of all kinds of degrees, undergrad, medical degree, and MHSC, right here from SVPH. And Dr. Liu has been in his present role since 2015. So we're going to hold questions between the speakers and entertain a question to the panel at the end of the presentation. So with no further ado, I'm going to turn the mic over to Larry.
Thank you, Karen. Good morning, everyone. I want to thank Karen and Stefan here for setting this up and for all of you to come and hear. This is more than a research interaction where we're doing research that's getting directly applied. The health and economic benefits study, which we're presenting from, is actually, we're doing the research together. The Health Authority, we work together regularly. Our staff, you remember Andy Hong, who recently left, and my PhD student, Vinay, who I don't think is here this morning, and others, we work together on a daily basis. We're doing this research together. It's not more a week or a month, a few weeks go by before Lyle will say, or James or some of his colleagues at Metro, I have an idea, I'd like to do this, let's test something different. How we measure regional accessibility or travel. They're not just consumers of the research, they're active research partners. So they're actually, engaged in the research process. So it's more direct than that. And as my career has developed over the last, Karen makes me realize how I'm getting older, that over the last 30 years I've been doing this. This is how I've operated pretty much throughout. Direct partnerships with end users from the beginning who tell us more directly, as opposed to publishing something and maybe useful or more useful had it been done a little bit differently. It's dynamic. And so they not only fund our work, they're part of it and use it. And I try when possible to publish directly with end users as well. So a little bit about, I think maybe I'll use this
No,
Do this one. Okay, cool. So this was in, I've been working on this topic for a very long time. In 1988, I did the first study really on active transportation and walkability. I didn't even know what to call it at the time. It was in Seattle. But in about 97 or 98, we published the first walkability map in the Seattle Times. A reporter, Eric Prine, picked it up, and I got a phone call from a guy working at Microsoft named Matt Lerner, and said, hey, you know, Google is just this new company, and they've been starting to map this thing, and we're going to create it. We'd like to do something with your work. It became known as WalkScore. So I helped create WalkScore, and they did it in a way that was airline distance, so a lot of people, their accessibility was determined based on being able to walk across water. And so we would show these maps, and we laughed about it. And I remember when I'm Jewish, and I said, well, I thought only one person could walk across water. You know? And it's like, you got a lot of Jesuses out there. So we got a grant from Robert Wood Johnson Foundation, and I gave them $100,000. It was a small amount of money they needed, but they fixed it and made they had their own money by then, of course. So we worked together and made WalkScore, Street Smart WalkScore, so people actually have to walk on the road network where they could. So anyways, in 2010, by 2010, there had been a lot of evidence, and I got asked by American Public Health Association to write a report and deal with the economic impacts. This was the first study of its kind done before, so we did this study showing that, that it monetizes. This was using a mortality-based approach, value of life. We don't do that now. We much prefer a morbidity, which is what this project is about. So we know that what we build in transportation does result in what developers will build. You're not going to get transit-oriented development near a freeway interchange. And if you do, it's not going to perform very well economically. Developers know this, and Lyle and James work very much directly with the development industry, or the municipalities do even more so. But TransLink does very much in dealing with transit-oriented development. Travel behavior and health and cost result. But the problem is the cost-benefit tools, and you may read the paper sometime that says that it's going to cost us $12 billion in lost productivity if we don't widen the highway. How many, everybody remember seeing articles like that? So there's tools in transportation. One of them is called the REMI model. It stands for the REMI Insight, the company that built it. And it externalizes the health and environmental impacts, the costs. So our goal is to bring the dollar, this is where this is heading, is we want the dollars, the externalized health dollars, because of the healthcare costs that come from sprawl and auto-dependence and environmental impacts. We want those dollars in the front end. We want to know up front how much it actually really costs before the decisions are made. So that's where that's gone. So there are 3 levels. I'm going to talk about detailed built environment characteristics. So we measure regional accessibility. That's working with TransLink more so and Metro, but basically how long it takes to get places, how long it took this morning, peak and off-peak. So I'll talk about that. At the smaller level, in the neighborhood, that's where you are in a region, capturing that. You can have a very walkable place out at the edge. That doesn't really perform well in terms of travel time. You're going to spend a lot of time traveling, probably in vehicles. Walkable complete neighborhoods, we'll talk about that, and then the pedestrian environment, which is not yet included in this study, but we measure that. So you can have a very walkable place, mixed use, dense, but the pedestrian environment, the street furniture, the lighting, the seating, the sidewalks, all aren't really quite right or there, and that's really important, and that's low-hanging fruit to improve health outcomes. We know in Canada we're in trouble, and the United States looks even worse, but this is the study, this is evidence, recent evidence from Canada, British Columbia, and Metro Vancouver. You can see obesity, high blood pressure, diabetes. Cardiovascular disease is definitely linked, and our evidence shows it clearly in this study and about 5 other studies we've done. This is not new for us. It is in the literature that we've got a real problem. So with the rates that we're looking at, even small, because remember, this is population level results. If you can reduce 1% diabetes, reduce the rate by 1%, a relative reduction, of course, that would be like a 20% reduction in diabetes. You have about a 5% rate. A 1% reduction actually is taking 20% relatively off the system. We showed in Los Angeles in a study we did last year that 1% reduction, 1.5%, resulted through a $13 billion infrastructure investment portfolio that they have in active transportation, yielded $100 billion in savings using the tool, that same cost-benefit tool used in that's used to justify highway investment, because workforce productivity follows healthy people, go to work, obviously school, and environmental and occupational health. This is the connection that we have. We can connect across to both environment and occupation if we put a little bit of time together and figure that out. But we know our results and the way the model works And we were shocked. We thought, well, we understand healthcare cost savings. How come this number is so big? They said, workforce productivity, much bigger than health savings. So, okay, people that go to work generate wealth and income. So anyways, the national background, we have the head of CIHR, I think, our Canadian Chief Public Health Officer gets this, 2017. Clearly, Lionel and James will talk about Metro Vancouver. The City of Vancouver is also funding this research as well, but Metro 2040, we mentioned, the Regional Transportation Strategy, Healthy City Strategy. We've got, our agencies are on this, they get it, and putting evidence behind it only helps them more, is necessary actually to uphold. This project is connected through a charter, so it's not just us researchers working with the clients, it's them working together. It further solidifies relationships or helps. They're well advanced and don't need our help to know how to work together by any means, but it does help increase the relationships between the agencies and one another, and clearly between the municipalities, the cities, and the regional agencies which you're hearing from today, who are then, and the cities, it's really the implementing agencies that we really, and TransLink is one, and also Metro indirectly helps that a lot and is essential. So our study goals are to investigate how the built and natural environment relate with health outcomes, and how those relationships vary by income and age. So we have really large sample sizes. This is prevalence surveys. I'll be talking about tens of thousands of participants. So we have age and income submodels, and that's critical because elderly, young, wealthy, less wealthy, poor, all interact with the environment, have different needs, and the relationships, the statistical relationships with environments are quite different. All this evidence, what we do typically in other studies is we take the evidence and we wire it into forecasting tools. So the regional agencies like Los Angeles and San Diego and Seattle and others are able to use the data, and we're doing this in Canada a little bit, but we're not as advanced on this in this part of Canada, although TransLink does this in its planning, it's quite advanced, that we then project forward, what if we were to develop in this way or that way, and how much does it cost relative to the benefits? And then investigate to the extent which walkable environments can reduce healthcare costs. So this is a diagram that it's a result of too much thinking, probably. I make up for it, don't worry. So weekend is upon us, I'm going to survive. So anyways, on the left, so this is sort of a left or right kind of, we start off, and these are the things that we can impact. Transportation infrastructure, land use decisions, density, mixed use, how far it is to shops and services, the pedestrian environment I mentioned, and also green space. So this then relates with behaviors and exposures. We've done it, in our work, we've done a better job focusing on the behavior side. So a more walkable place with good transportation, we then measure and say, aha, people are more physically active or spend more sedentary time in sprawl. And we measure how that relates with obesity and chronic disease. And then social interaction is important, and we measure that a lot. We're very interested in that impact. And then that also, but we can't forget, of course, and environmental health says, and other colleagues here we know are very steeped in this area, is the exposure side. So that's critical. And putting them together is what we have failed to do very well so far. This study does not have yet air pollution exposure in it. It really should. So we hope to do that in our next phase. So that's, you start off and you do some, and then you add the next piece. But we see it in our results, which I'll show you. And then the mechanisms, weight, inflammation, and stress, and how they interact. So we can measure biological response with certain types of data has that information. And then we get physical and mental health outcomes that you can see and cost. So that's kind of the fully blown model. That is the research program and its objectives in whole. And that's where, right now, this is under review, this model with literature to date on these links in the Journal of Transportation and Health. More simply, I could have just shown you this. It's not as interesting. So we all get that. But it's, I think that there's a philosophical question, is it morbidity or mortality that we should be monetizing? You may have heard of HEAT, which the World Health Organization uses. Its tool, it uses mortality. I don't personally believe that's the way to go. I think morbidity, keeping people well, and obviously dealing with the cost of illness is better, but there could be an and, not or, on that. So here we go, phase one, we got a grant from CIHR, a small grant, but monetizing using the generations data set that we know John Spinelli and now Trevor Dummer lead, which is in SPPH. We are the lead in SPPH of the British Columbia site of Generations, which is a longitudinal survey. So we took Generations data, and then we're monetizing using electronic medical record link and matching that to walkability, to the characteristics of where people live. So how much do people spend on healthcare based on where they live? That project had that project, and then went to everybody here and said, we got this project, and the Health Authority just collected the My Health, My Community survey of 33,000 people. We'd like to use that data set as well. And so they liked the monetization piece, and so we all worked together and created phase 2, which is where we are now. The Real Estate Foundation, who's not here, was a key funder. Now we have, of course, next steps, and I'll get to that in a moment. I need to move along. So here it is, thinking about My Health, My Community. Is linked to our built environment database, which I'm about to explain, which is our core function in the Health and Community Design Lab, which is where all this work is based. I have my staff, a lot are here right now, who work in the lab. Avital, may I raise show who you are. And Bean, who's new, working in the lab, our new postdoc, and we have a couple new folks. We've been here about 11, 12 years. The lab is doing all kinds of applied studies around North America and elsewhere. So the built environment data set is one of our core functions, that walkability data set, and how to link it with health outcome data sets. BCGen is the other data set I mentioned. So onto the walkability data set. So we have, this is amazing that now we're been doing this a while. We did it in 2006, measured walkability, 11 and 16 matched to the census data. So we're now able to do change detection. This is parcel level, small area measurement of the entire surface of the region. Every postal code has been buffered, and I'll show you how we built it. That change detection can be used, and James will talk about this, to track the implementation of the regional growth strategy. They hired us to build it for that purpose. So it's literally going to be using to track the implementation of our regional plan and how municipalities are complying or not. And hopefully one day dollars get put behind it to reward compliance, so they know if we make our community more walkable and that leads to health outcomes, we're going to be more able to access funding for transit, for non-motorized improvements, infrastructure support, so you have those incentives in place, and it's all measured, and a report card is objectively calculated. So this is how we measure walkability. There are actually 5 measures now. We have net residential density, compactness, how many dwelling units per residential acre, mixed use, live, work, play, connectivity, intersection density, but that's a gridded road network or cul-de-sacs, throughput, stuff's nearby but you can't get through or you can, and then something called retail floor area ratio or FAR. So as planners, everybody knows it, developers know this, but this is basically, is a building, when you're walking down the street on 4th Avenue, notice the buildings are all up to the curb, that's a high FSR, meaning that the building fills the building envelope. Go out to Boundary Road, it's set behind a sea of parking, low FAR. Not good, not walkable. That proxies and picks up all that pedestrian environment stuff that we're not yet measuring. So we have it in there indirectly through secondary data. So the walkability surface we just completed, Felician, we had a researcher from Belgium who just left, finished building this recently. This is our 2016 surface. It is very detailed at the small area, but that's the map of the whole region. So any of you who have a data set, we're going to probably help with another new project that's underway called Child. Child's a big study underway. You can land any data set. You have address information, we have walkability. We can tell you the environmental context in which your participants are being impacted daily. We just need a postal code to match it. We have all those measures. So here's how it's built. Every postal code has a little centroid in it, a dot, and then we grow a buffer on the road network in GIS using a measured approach. We published a paper in International Journal of Health Geographics about a year ago, testing through 5 countries. We have a grant in the US, NIH grant, that is multiple countries around the world, and we picked 5 countries where we had all the same data and validated it against objectively measured physical activity using accelerometry. So this was the best performing approach to date of how to buffer. I can go into more detail about that if you're interested later, Q&A. Here's our measures. We buffer, pull in all the parcels, all the characteristics, and we get these measures. We got our commercial floor area, that's the floor area ratio. So these are the levels of variation across the region. So that's, each measure here is intersection connectivity, net residential density. Oh, we have a new measure in 2016 because TransLink was able to collect, and we've done this elsewhere, sidewalk data. So we, for years, had walkability without sidewalks because we couldn't get that data secondarily. We'd have to go and audit using Google Street View, which didn't exist before. We'd have to walk up and down every street. So we decided we were not going to do that. But now that the data is available, we have it in our data set. Can you imagine? So it's very cool now that we have that, we're able to talk about changes in walkability. So this is just 2011 to 2016. Well, who's getting more and less walkable? And actually, less walkable is not happening so much, but actually yesterday night, there were planning directors on the West Coast all got together. There was an event downtown. And places are actually, wealthy areas are actually taking apartment or whatever and consolidating and building in Seattle where there's huge wealth creation and actually going lower in density. That's not happening here as much. But anyways, places that are getting more walkable are the ones to look at, and they're brown. So we were able to do the change detection. Regional accessibility is a fairly simple concept. The time it takes to reach a wide array of regional activities from any given location. So it's where you are. We use TransLink's travel model to do that with, projected congested speeds. There's a travel model that's used to inform investment, of course, you hope. And that's what all the travel surveys that TransLink does help feed into. We have it for peak and off-peak, and for transit, and for driving. And we use it a lot in our research because if you don't control for regional accessibility, you don't know what you're looking at. Walkability doesn't really, it would mask what's something else, which is travel time. And then you'd be pulling a lever that has nothing to do with the main lever that's affecting behavior. And we do that really well in research, so we try to avoid that. But this is AM peak, and it just shows you the yellow for every single location, how many people, this is population-based accessibility access within an hour. So this is what I wanted to get to before I start to wrap up. In the My Health, My Community data set, so I'm just going to show you one example of the results, I think. So this is walkability, how it affects behavior, chronic disease, and social and mental wellness. So we're all pretty used to seeing these diagrams, but so walkability left to right is low to high, and we've quintiled it. We're now octiling it, if that's the right term, because we want our decision makers to have more variation, and we have a big enough sample size to do it. But low to high, and you can see the referent group is always Q1, least walkable, and as you move up the walkability continuum, you see a significant difference in Q3 for transport walking becomes significantly greater. This is self-reported. We expect this, and we see it in many data sets. Physical activity gets significantly different as you hit only the 5th quintile there. It's just self-reported, not great data. Accelerometer data is what we usually use, but we don't have that in data sets of 35,000 people like this. So this is good to get. Chronic disease is what's new. And you can see reductions, you hit a significant, so let's go for BMI, Q3, red, is significantly below the line. The crosshair, the whiskers no longer touch, and then Q5 even more so. So that behaves as we've seen in the past. Now new is diabetes, high blood pressure, and heart disease. Diabetes, you gotta hit Q4, and then Q5 also stays down and goes down more, so that's great. So we're seeing that, that's payoff. That's what we saw in Los Angeles with studies in California using the health interview survey. We've seen it elsewhere and we see it here. High blood pressure also behaves at Q5. We've got what we call a hit. Heart disease, interestingly, most is that not until you get up to Q4 do you get just barely significant result, and then heart disease goes back up in Q5 as density gets greater. So what might be going on there? Air pollution exposure, noise, all kinds of stresses that the most urban, so we need to, that's why we know we need it. So it's in the data, we see it. Social and mental health, stress goes significantly down, maybe less commuting, and a sense of community very much significantly higher at the top end. So I need to wrap up. I think I want to ask where we are time-wise.
20 minutes.
I need to wrap up so there's time. So we also have measured parks, good result on green space. I'll just summarize in a statement that we know that access to green space Matilda's here, who's doing a whole big research program on this topic, but green space definitely not only is significantly related with health outcomes and predictive. Our study shows very good results, as you can see just by looking at the numbers or the results there on chronic disease. Also on that stress and sense of community works as well, but it actually monetizes really well, and that's it's absorbing wealth, though. The issue is that can't tease out green space from wealth, and so we need to talk about how to deal with that. The generations data set, I don't have time to show you, but I can say that it confirms the same results. So we've got two different data sets triangulating and showing us the same results, which is great from a policy perspective. So generations works really well. So tying it all together is our goal now. We're using a structural equation modeling approach to do that, to go from walkability through over to chronic disease, and the path models worked out really well. This is very important because these are kind of the gears and how they all connect to go from walkability through behavior to chronic disease and cost. So this has all actually been statistically significant, and the results are great. So walkability affects behavior that we know relates with behavior, chronic disease, healthcare utilization, and cost. And in summary, I'm not going to say all this, we're learning a lot, and walkability is related with higher rates. You know, I think I just showed you the results. So, but basically, I think it's the next steps is we're going to complete all this, and our future next step is to integrate air pollution exposure, look at the pedestrian environment more in detail, and then work with our implementing partners on actually applying the research to the implementation of the plans and tools we have, and maybe, if we're fortunate enough, help justify the economic argument for the Broadway Corridor to extend to UBC. Thank you.
Okay, James Stiver is up next, Metro Vancouver.
Great. Good morning. Thank you for having me to be a part of this conversation. It's an exciting project. So, as I was introduced, I'm James Stiver. I'm the Manager of Growth Management and Transportation at Metro Vancouver. That team is part of the regional planning group at Metro Vancouver, which is part of the broader Parks Planning and Environment team. So, for those that don't know, Metro Vancouver is a regional district that comprises 21 separate municipalities, an electoral area that Metro Vancouver is responsible for, and a Treaty First Nation, which is Tsawwassen. So the role of regional planning at Metro Vancouver is to work with our member municipalities and jurisdictions to write and implement regional growth planning and strategy, and to manage the built natural environments for the betterment of everybody in the region. Primary way we do that is through Metro 2040. Larry mentioned that earlier on. That is our regional growth strategy, which is dictated through rules set by the province. It is a plan to draw out growth and change in the region to the year 2040 to accommodate population, housing, making the region livable, trying to preserve green spaces, making us sustainable and prosperous going forward in the future. So how do we achieve this? Not an easy task. A lot of moving parts. Metro Vancouver has a number of strategies that we have worked on over years, and we have evolved, and we are still evolving. The strategy that the growth plan sets out today is building complete compact communities that are connected by transit, making it easier for people to make choices when they want to get around or have to get around for work or play. We have an urban center structure in the region where most of the density, 40% of all population growth, is to be directed into those, and they're distributed throughout the region. These urban centers are connected by a network of frequent transit corridors. So Metro Vancouver works very closely with TransLink to plan and enhance transit corridors to feed these urban centers and connect them for people to move around and to accommodate our growth. So the benefits of centers. There's many benefits of this kind of strategy, and they're playing out over time, and we can measure them in a very quantitative and qualitative way. Our strategy of compact growth in this network of centers and corridors maximizes investment in transit. So when there's a limited amount of public money going into transit and other infrastructure such as water and sewer and roads, there's often a critical analysis done to determine the return on investment or the biggest bang for the buck. So we try and avoid inefficient or costly infrastructure that is underutilized. This structure also protects green spaces such as forests and watersheds where we get our drinking water, and keeps the growth in places that are best supported by infrastructure and most efficient. It reduces suburban sprawl. It reduces the need for personal vehicle use if you don't have a choice, and it helps lower air pollution and greenhouse gases as a result, and of course traffic as well. Fourth benefit that is very key and has really come about with the result of the work that we've had with Larry and the Health Authority and TransLink is this health outcome from compact urban growth. So over time, we're continuing to learn more about how density and growth has a direct impact, positive and negative, on public health, and creating livable and walkable communities and what that does for people's physical and mental state of being. So the more people that can meet their day-to-day needs by walking or cycling and not having to choose to take a vehicle, that increases their physical activity and health outcomes, as Larry was touching on. So this obviously translates into healthcare savings and provides a preventative measure for many disease outcomes. So there's that positive piece as well. So working with UBC has been an exciting opportunity for us at Metro because of the measures that are coming about to take the decisions made on density and walkability to a new level. So we will definitely be applying this going forward. So this study, the outcomes of this study will help municipalities, help us at Metro and our municipal partners make the case for active transportation infrastructure. So retrofitting communities to make them more dense and more walkable is a very controversial thing, and it will become a much bigger issue going forward in the future. With our urban containment structure we have and the agricultural land reserve that's in place, we don't anticipate that changing at all over the long term. What that results in is a significant increase in density and redevelopment in our communities. This issue is going to become much more prevalent going forward. So if you just think about the extreme controversies that come about from implementing a bike lane or changing a single family home to a duplex, you can imagine what quantum increases in density is going to do in this region. So having data and justification for policy decisions is always a significant benefit. So this study provides municipalities, Metro Vancouver, TransLink, with a stronger business case when you're looking to implement new and walkable communities and change densities over time. So this will give us better data to say when changes are made, it can save lives, it can save costs, it can reduce costs to our healthcare system. There's also positive health outcomes for individuals, and that is such an important piece for people understanding why change is important. So you guys skipped over a slide. Oh, no. So Metro 2040 is a plan for building more walkable and complete communities, as I noted. We have a dashboard on the Metro Vancouver website that we're building over time that has a number of metrics. The health outcome data is going to be feeding into new metrics on our dashboard. We have a responsibility to monitor a number of these metrics from the province, but the Walkability Index Service provides an additional metric to evaluate the success of the regional growth strategy in the area of public health. So this moves better towards quantifying the outcomes of policy and development decisions on the ground over time. I don't know why these things are out of order. So the study has identified a number of areas for us to expand our policy research into. How to foster healthier communities, and Larry touched on the interesting fact that when you get to a certain density point, some of the health outcomes actually start to go backwards. More work is required to tease that out exactly, but this is not an exercise of pushing density as far as you possibly can and having infinite positive outcomes. So we all recognize that there are many lessons that still need to be understood and worked on, but it certainly is a great conversation to be having with elected officials and members of the public about what is an ideal community and pulling out examples of what have positive physical and mental health outcomes in our region. So density is not the end-all be-all, but it is an important tool that we really need to understand better. So Larry certainly talked about this at length, but we certainly commend UBC for looking at the positive implications of policy research. We do a great deal of research at Metro Vancouver, and I know our friends at TransLink do as well. But to have another party at the table where we can share resources, share knowledge, share an understanding of positive outcomes, and the health authorities as well, everybody's going to be better off for it. So I think we're setting a very positive move going forward that I hope will continue and be explored through further projects. So this is all about relationships, about building a positive region and a much healthier community. At Metro Vancouver, we have very strong relationships with our friends at TransLink, and we're going to be building other positive relationships going forward on all sorts of different projects. On the horizon, we are going to be working closely on the next regional transportation strategy with our friends at TransLink, which is a projected plan to the year 2050, and we're also in the early stages of working on what we're calling the Long Range Scenarios Project, which is looking at the future of population, housing, and employment in the region to the year 2121. So it's an exciting time to be pushing the envelope out into new areas that we've never explored before and building new partnerships, and it's a very exciting time to be sharing knowledge and with the objective of building much better, healthier communities for all. Thanks.
All right, Lyle Walker from TransLink.
Hi everyone. It was about 25 years ago when I was here at UBC and as a graduate student under the guidance of abilities, I did my master's thesis on how urban density, similar to what we're talking about today, the built environment, impacts a household's ecological footprint. And as a student, we were thinking, well, it's really interesting research, but how do practitioners use that information? Fast forward to the future, now I'm a practitioner, and as a practitioner, I want to have the evidence base to help us make more informed decisions around the region. And that's what is so important about what we're talking about today with having these partnerships, these labs, to really bridge that gap between some of the research that's done and practice, and particularly impacting and influencing decision makers which impact the outcomes that we're interested in. We've been a strong advocate and supporter of collaboration with our municipal partners, with Metro Vancouver, the health authorities, and the academic community. We've really appreciated working with Dr. Frank, particularly over the last 10 years on some of these linkages between land use, transportation, and health incomes. As Larry mentioned, we're currently sponsoring 2 studies in conjunction with our partners, and we see a lot of value in this in terms of being able to leverage our resources together to further the development of the evidence base and to make better decisions within the region. So TransLink is not just the transit agency for the region. We are a regional transportation authority. Some of you may not know that we also co-fund a major road network with our municipal partners. We also cost-share walking and cycling investments with our municipal partners. And we also have some of our own regional cycling infrastructure as well. And so these health outcomes are important to us. As Larry and James mentioned, we have a 30-year regional transportation strategy, which we're just embarking on with Metro Vancouver and other partners right now. And our current regional transportation strategy does have 5 goals. They really reinforce a lot of the regional growth strategy goals. Things like providing sustainable transportation choices, supporting a compact urban area, fostering safe, healthy, and complete communities, enabling a sustainable economy, and protecting the environment. We have 2 headline targets for our current regional transportation strategy. One is to achieve a mode share of 50% by sustainable modes, so walking, cycling, and transit. And another one is to reduce the per capita VKT, we call it vehicle kilometers, traveled in the region by 1/3. And even though it's not mentioned here, that accessibility to destinations is also a really important goal, and we use it in some of our evaluation metrics when we're looking at different projects. And we identify in our regional transportation strategy, it's not just achieving those, but also what ultimate outcomes those generate. Things like reductions in greenhouse gas emissions, criteria, air contaminants, as well as health outcomes. And we specify that some of the benefits include people living healthier and more active lifestyles. So what are some of the potential applications of this evidence base between land use, transportation, and health? I'm going to speak to a couple different applications from a regional transportation perspective. So as I mentioned, we're responsible for this 30-year regional transportation strategy, and then you're probably also more familiar with our 10-year investment plans. Our last investment plan was adopted by our board and our mayor's council a couple of months ago, which was studying new rapid transit and other transit investments and walking and cycling and road investments in the region. And so we intend to use this to help monitor some of the change over time in conjunction with Metro Vancouver. For our last regional transportation strategy, we actually, with both of the health authorities, we conducted a strategic health impact assessment of different alternatives. And also some of the background work that was done by Larry Frank was also looking at how to integrate health considerations into regional transportation planning. And we can also use this type of information for our sub-regional plans. We call them area transport plans. And we can, are also planning to use the updated 2016 walkability data, which includes the sidewalk inventory data, which we provided to Larry Frank's group a couple years ago. Another use of this data is for what we call transit-oriented communities. And so we work closely with Metro Vancouver and our municipal partners in providing an evidence-based and guidance to those municipalities to develop more transit-oriented communities. We use a framework called the 6 Ds of transit-oriented communities. And this includes good accessibility to destinations. It also involves having shorter distance to transit, a tighter road network, pedestrian-friendly design, higher densities that are also more mixed use in nature to have that diversity of land uses around the region. And then we also add on demand management, because the parking and pricing is really important for influencing people to walk, bike, take transit, or to take their vehicles. And so a lot of the things that are in the walkability index relate to some of these Ds, and so this helps further us understanding the relationship between these different variables. A second application is for our business cases. So James talked about making the business case for active transportation, not just for municipalities, but also for us at TransLink. We've had a long-standing cost-sharing arrangement that we have with municipalities for cycling infrastructure, which is fairly modest. In our last 2 investment plans, we've made the case for a substantially higher investment in cycling. And then for the first time ever, our agency is cost-sharing walking investments with municipalities as well, things like sidewalks and crossings, because being able to get to transit, you need that supportive walking environment. Also, what's also really important is for some of these major investments, TransLink does not fund those solely. We need senior government contributions, and particularly for the provincial government, these health outcomes and the monetization of the health benefits of these major investments is really important. The Surrey Newton Guildford Light Rail Transit did include a health benefits assessment to help monetize and quantify some of those investment benefits, and then we can share that with our potential funders. And for the discussions about the potential expansion of rapid transit from Arbutus to the rapid transit to Arbutus, extension of the Millennium Line is included in our phase 1 plan. That's anticipated to open to 2025, and I understand there's some initial discussions about extending rapid transit out to UBC, and I think the health benefits are going to be an important part of that discussion. And then the last potential application is this walking access to transit cost sharing that we have. And we can use things like the Walkability Dataset, the sidewalk inventory, and then our compass card data lets us understand what the number of people who are, we call it alighting or boarding at each transit stop in the region, and also at our rapid transit stations. And so areas that have high walkability, lots of transit demand, but maybe there's an absence of sidewalks. And then we can flag those areas with our municipal partners, and then they could either invest in those on their own in connection with some of their other criteria, or they could use that for approaching us for cost sharing for that infrastructure. And this is the walking infrastructure to transit is a pretty major program now at TransLink. It's about a quarter, it's $25 million almost in terms of funding over the next 10 years, and that's matched dollar for dollar generally with municipal funds in the region. So we really do value our partnerships with people in the room today, as well as our municipal partners, and of course both of the health authorities as well. And this is exactly the type of partnerships that we want to be working on going into the future, and we look forward to continued collaboration.
All right, and Dr. James Liu, Medical Health Officer for Vancouver Coastal Health Authority, Environmental Health.
Thank you, Karen. Good morning, everyone.
It'll come up in a second.
Okay, this is me. I'm just want to recap, and I don't think I'm going to read the slides. Basically, this is about the chronic disease and obesity burden, from both in terms of healthcare utilization as well as direct and indirect cost. I think that, well, Larry has given us a picture of the causal pathways for many of these health outcomes. And I think the question for us in the health authority is how can we in the health authority, and how should we in the health authority influence the different paths in the diagram. And as you know, that traditionally the health authority mostly deals with the very end, sort of the very last end of the health outcome sort of pieces. But I think what we want to do is to move certainly further, much more upstream. So what are the things that we can do? And I'm just going to give you some context. From a top-down approach, first of all, you have the Public Health Act in British Columbia. In one of the sections of the Health Act, it says that the medical health officer needs to provide independent advice to local governments and authorities on bylaws, policies, practice, respecting health issues. The second one is there's a document called BC's Guiding Framework for Public Health, and that's produced by the Ministry of Health. And it is the vision or the strategic plan for public health within this province. And the first goal, or the first visionary goal for this framework is about healthy living and healthy communities. And it's about supporting communities to make it easier for people to make healthy choices. And then to translate that into action, what the Ministry of Health has done is in their letters of expectation to health authorities that to ask us to be starting to have form relationships with local governments and within our respective health authorities to move the dial, if you will, and go upstream in terms of chronic disease management. You could also say that if you were just to simply use a top-down approach like this to kind of go out there and do work, it doesn't really work very well. People don't really like that top-down approach very much. And so what we need to also look at is sort of the bottom-up sort of thinking, looking at how can we find alliances that are there already and build that relationship, keeping the obligations we have in mind, but certainly focus on building relationships and partnerships. So what I have in this slide are just the vision statements of the different organizations represented here this morning. We have Metro Vancouver, Coastal Health, TransLink, and UBC. And I think it's not that hard. Looking at what we're supposed to do and what our vision is in terms of community and our place in the world, that there are a lot of commonalities and there are potentials for us to work together. And so building from the top down and bottom up, we can find ways to work together. And how do we do that in terms of within the health authority? I like to think of it as sort of a population health approach. And there are four components to it. We need to provide some leadership when we should be. We certainly need to participate in partnerships, advocate when we should be, in the place of advocate, being an advocate, and certainly be involved in healthy public policy development with our partners. I'm just giving you some sort of examples of in terms of the four components. And you may think that under leadership, I put my health, my community, and I think Larry pointed out, has already spoken about it. You may wonder why that is a leadership issue. Well, I think it's a leadership in the sense that the health authority was willing to invest, solve a gap in data, a critical data gap in terms of how we understand at the local level, very small local sort of aggregate units in terms of health behavior. And so we were willing to spend or invest in getting my health my community survey done. So that to me is an example of that type of leadership we need to report. And I'm glad to report that we are working on the second round of my health my community right now, and we hope to launch that early next year. And so we'll have some longitudinal sort of trend data as we go along. A partnership, and certainly with Metro Vancouver, we have a seat on the Regional Planning Advisory Committee, so we interact with the planners. We also are working with local municipal planning groups as well, and we this talk this morning is about that joint research, and we certainly have participated both with UBC, TransLink, and Metro Vancouver, a number of these joint projects. And I think one of the important things for our participation, and I think Metro Van and TransLink has, and Larry has mentioned already, is that for us as practitioners in the field, the important thing is to have a place of formulating or setting the research questions so that what's done are very useful to us in the field. And we're very happy to have that kind of interaction that allows us to do that. And occasionally we do have data to share, and we're happy to do that like my health, my community. Advocacy, and certainly one of the examples we have is that we did do quite a bit of that type of work during the unfortunate failed transportation transit plebiscite in 2015, but when we did produce, using my health, my community data, a lot of fact sheets around the importance of public transit, around the importance of looking at this issue of funding transportation in a sustainable manner. We wrote letters to the editor, and we were advocates, but unfortunately said that was sort of something that was worth doing, but it's something that we will continue to do when the opportunity arises. And in terms of public health policy, I think here it is about knowing or can we look at regional growth strategies and regional transportation strategies as healthy, potential healthy public policies, and not just sort of urban planning, but can we help our partners to use a healthy public policy lens to look at some of the things that we're doing, and I think they have, and we're glad to be able to help them whenever we can. A particular piece of my interest is around mobility pricing, and I think a lot of the arguments it's around demand management, but But certainly there is a healthy public policy piece that we can look at. It's certainly something that I look forward personally to more discussions around that. And in terms of healthy public policy, I think one of the pieces that we must not sort of forget is equity that's sort of built within that principle. And helping to look at how to make sure that when we're doing healthy built environment work, that equity lens is there, and making sure that we're applying that principle to the neighborhoods in an equitable way. Looking ahead, I think Larry and others have alluded to, and that's sort of looking at using the evidence we have now. It's getting more and more, and moving towards more of a quantitative way, looking at quantifying the health economic pieces to help to build that business case for our partners, so that we can advance the healthy public policy plan. Larry has already mentioned around heat from WHO Europe, around our heat tool. But if you look at the things that we are doing with Metro and TransLink in terms of regional growth strategy, in terms of regional transportation strategy, and look at some of the projects that are on board in the future projects, I guess my vision or my hope is that one day we will have a own local regional specific kind of a very rigorous, consistent economic assessment tool that will help us to advance community planning so that they will truly become healthy public policy documents. Thank you very much.
Okay, I would like to invite our 4 speakers. Please come and, keep it galley, right? So we started a couple minutes late, so we're just going to go a couple of minutes over because I would like to entertain questions. So we're going? Okay, great. So questions from the audience for any of our speakers or all of our speakers? Great.
Good morning and thanks for being here. I think everyone in the room has a vested interest in the Broadway Corridor. So what would be, in your best assessment, the health and economic impact, incremental, so relative to what we have now, and does it even matter in a highly politicized environment?
Who would like to take that?
That's so coming your way.
You're right, it is very political, and so our decisions are made by our board and our mayor's council, so it's not just the city of Vancouver and UBC and the University Endowment Lands that are involved in the decisions, it's the whole region. And all the rapid transit projects that I've seen have had a significant political element to it. I think it's worthwhile to definitely incorporate the health benefits. Like you said, what are the incremental health benefits associated with rapid transit in whatever form, whether it's LRT or extension of the SkyTrain out here, and then the economic benefits. And I think usually the health benefits are underestimated. I think it's a big factor in terms of the multiple account evaluations, benefit cost analysis, and it should be going forward. And ultimately, there's going to be some type of funding decision that would need to be made by the region, the TransLink and the Mayor's Council, by UBC, who's indicated that they're willing to come to the table, and then the federal and provincial government, and it was really the provincial government who benefits from the incremental health benefits associated with that. And so it's having a business case that appeals to all those different funders, as well as some of the other people whoever would help fill the funding gap, whether it's taxpayers or the development community or whatever that may look like as part of the funding discussions.
As part of this project, Craig, we have an outreach program that we're starting now, and we'll be working on how to package all the results into briefs, as well as a report, small, easy to understand implications of the research and targeting it at some specific decisions. That's one. So I've spoken with Michael White, campus planning and partnering, UBC as an entity, not the research side, but the actual development side around that question of how to apply the results. And as Lyle said, maybe we're not going to be doing that work, but really how this type of evidence and other evidence and tools that are out there could be used to make the business case for that extension from healthcare cost savings, workforce products. It's all in a line. I mean, it definitely is all there, and if we could show that it saved money by building the line. It depends on what period of time, how far out you go.
Just to lend a little different perspective to it. So as I was talking about the growth strategy for the region is a series of centers with connectivity between. It's always important to connect urban nodes with higher orders of transit. There's currently a B-line service out here, so that does tick the box. When it comes down to is that when, what's the threshold to move to that next level of service? It's often, bums in seats. So when there's discussions around development plans, the future of UBC, the amount of traffic that's going back and forth, that often builds the business case. It's important to keep in mind that these things are not just static purchases that are made one time. The introduction of an extension of the SkyTrain has significant long-term maintenance costs, operational costs over time as well. So that'll all come into play, but definitely connectivity between nodes is always something that we are looking at and making better.
Yeah, I guess I have to say something. I was just going to say that actually we asked Larry last year to do a literature review in terms of how other people have evaluated the construction of rapid transits and looking at lessons that we can learn from that in terms of how to do that sort of outcome analysis. So I'm sure that will be coming. Just from a broad observation sort of perspective, I think the piece that Larry has mentioned that we need to sort of include in any of that future evaluation is the air pollution side, and sort of environmental side, air pollution and noise, sort of looking at the changes in the landscape as that subway comes into being.
Okay, maybe one more question. Okay. Well, Jen, please join me in thanking our speakers today. And we got here, you got here, and we're very grateful to be here. Thank you so very much. Thank you. And next grand round is going to be October 26th, and we will see you there. Thanks.